John Mascarenhas from the Icahn School of Medicine at Mount Sinai in New York City. Today we'll be talking about which patients are ideal for telomerase inhibition in myelofibrosis. And I think these patients that we are targeting in the IMPACT MF study are patients who have been on ruxolitinib or a prior JAK inhibitor, namely ruxolitinib, and who have failed therapy. The patients who are primary refractory, who've not had adequate response from a spleen and symptom perspective, but also now we're looking at patients who may have had an initial response and then loss of response. These patients we know from multiple studies do not do well with a median survival of approximately 14 months and have limited options. So it is really an unmet need after failure of JAK inhibitor therapy, and one in which there's a lot of clinical investigation to salvage response. Imetelstat in phase 2 study has shown spleen reduction in a modest proportion of patients, about 10%, SVR 35%, and 30% symptom improvement, 50% or greater. But probably most impressively and most provocatively has shown improvement in overall survival with a median survival at 9.4 milligram per kilogram IV every 3 weeks of nearly 30 months. Which was superior to the lower dose that was also tested at 4.7 milligram per kilogram every 3 weeks, which was closer to 19 months, and far superior than multiple studies, even a propensity score match study of about 14 months median survival once someone has failed ruxolitinib. So this really gave a lot of confidence and support to run a randomized phase 3 study of patients with ruxolitinib failure, randomized to either imetelstat at the dose of 9.4 milligram per kilogram every 3 weeks, or best available therapy, which excludes a JAK inhibitor, with a primary endpoint of overall survival. So when asking the question, ultimately, which patients would be ideal for telomerase inhibition, I think it would be patients where survival is the goal, is improvement in survival. Because right now we do have drugs that are quite effective in salvaging spleen and symptom response. But these drugs are not necessarily anticlonal, and imetelstat has a wealth of preclinical data and rationale supporting its anticlonal stem and progenitor cell activity that we think underlies its ability to improve survival in these patients. And right now, the first step of doing that is confirming it in a randomized phase 3 study. But you will see and are already seeing other approaches earlier on in investigation, such as imetelstat plus ruxolitinib earlier on in the disease course. And I think there's a lot more to come. So I think this is an interesting and exciting area of investigation of targeting the stem cell, the malignant stem cell population, with the expectation of prolonging survival, progression-free survival, and outcomes of our patients. And this doesn't preclude transplant. So for some of the patients, this could even be a bridge to curative therapy with transplant. So we have a lot to look forward to as the IMPACT MF continues to enroll and ultimately reads out with a primary endpoint of overall survival. I'm John Mascarenhas. Thanks for listening to me.